We will now have our next speaker, Dr. Sharon Koehler. Yes, and you will speak to breast health. Thank you.
Good morning again. Very nice to be here. And I have, I think, a very important talk to all women and men. Before I get started, men can get breast cancer, so please pay attention, okay? But mostly women. And I want to also say, if anybody wants to interrupt while I'm talking and ask a question, in limited amounts, that's okay. I would be very happy. I like to have more of an interactive talk, less of a lecture. This is some contact information in case anybody ever needs to reach me. These are the two offices where I see patients. And we're going to be talking today about a lot. I tried to cut it down to fit into the 30 minutes, but it's a huge topic. So we'll talk about our statistics, prevention, screening, risk factors. I want to go into detail about breast self-examination, and then we'll have a little quiz and questions at the end. And I do put a lot of emphasis on the breast self-examination, especially because it's so important to everybody. Women all need to know the proper technique and what to look for, and as healthcare providers, we really have to remind our patients and teach them the proper way to do a breast self-examination. Breast cancer is rather prevalent in the United States. It is the most common cancer other than the skin malignancies in women in the United States. It is the second leading cause of death in the U.S. We get about 280,000 new cases between the invasive cancers and the in situ cancers. Those are the lower stage cancers in total. So it affects a lot of women every year. But what's really wonderful is that there are only close to 40,000 deaths. So please keep in mind, most people are cured when they're diagnosed with breast cancer. We are not seeing a large number of women dying from the disease. It is not a death sentence. But it is, again, very common. 1 in 8 women may get breast cancer, but only 1 in 35 will die from it. And which leads 2.5 million women in the United States living as survivors of the disease. Does anybody in here know a survivor? I think I see almost every hand. So it's such an important topic. People want to know how to prevent breast cancer. HIV/AIDS, that is preventable. A lot of diseases are preventable. There are a few ways to prevent breast cancer. A couple of things that people can do, people who want to prevent cancer, can try to maintain a healthy weight. We know that postmenopausal obesity is a significant risk factor that increases your lifetime estrogen exposures, and anything increasing the exposure to estrogen is going to increase your risk for breast cancer. So please maintain a healthy weight, especially in the postmenopausal years. A low-fat diet is very helpful, and especially a heart-healthy diet. Whenever my cancer patients ask me what they should be doing for their diet, because cancer patients, especially once their treatment is done, they want to continue to be active. They want to continue to do something to help prevent the cancer from recurring. I always recommend a heart-healthy diet, because we want to maintain, a strong physical body so that we can prevent disease. Our immunity is better. It's just the healthiest way to live. So the heart-healthy diet. Vitamin D deficiency has been shown to increase recurrences. We believe that it may also increase your risk of developing breast cancer. There are a lot of studies ongoing. So for many reasons, vitamin D should be checked by your primary care doctor and should be addressed if it seems to be low. I also have a lot of questions about soy products, because as we know, soy is a phytoestrogen. So in theory, it should actually be bad for women with breast cancer, and it has shown to increase recurrences for women who have breast cancer. But then on the other hand, there are studies that show that women who eat a lot of soy, some of the Asian populations eat a lot of soy in their diet, they tend to have lower rates. So I don't know what to tell anybody except moderation. Everything in moderation in this life, I think, is a pretty good rule. So lifestyle, again, we can affect our risk by limiting alcohol use. 1 glass of red wine I would never speak against, but anything to excess would also increase your risk for breast cancer. Exercising regularly is always a very healthy thing to do, and it also has shown to decrease risk for breast cancer. And if you are having children, breastfeeding will help both the child and your risk for breast cancer. And avoiding hormone replacement therapy if possible. There are exceptions. It's not a hard and fast rule, but if you can, it has been shown to increase risk. And environmental pollution goes without saying. It's going to affect a lot of women in many ways. I wanted to talk about some disparities because I understand these, this is going to be transmitted to Africa, and African American women are also going to be finding this talk relevant. There are disparities for a number of reasons with breast cancer. African American women tend to have maybe a slightly less incidence of breast cancer, but they develop it at earlier ages, and they have a more aggressive form of the disease. So it's extremely important for all women, and especially African American women, to really be aware of their bodies, not be afraid to go for help. The other problem is that sometimes the African American women are more likely to die from the disease, not necessarily because of the aggressive nature, but they may have poor access to health care. So it's been shown that it may take longer to get the same treatment that someone else might get. So it's very, very important to open the doors for access, for screening, and to keep people in their thoughts and to educate. So risk factors that we cannot change, I just wanted to point them out, are our reproductive history. Having children later in life is a risk factor. Menstrual history, you can't choose when you start getting your period and when you stop, but the longer you're exposed to estrogen, so the longer that cycle, the higher your risk. Genetic factors are a big risk. We can't choose our families. I pointed that out today. Radiation is a risk, treatment with DES, race, your family personal history, and your age. Obviously, as we get older, risk increases. But there are worse alternatives. We want to keep getting older, right? Okay. Now, these are things we can change, though. Not having children, I'm not going to tell everybody to go out and start having children so that you can decrease your risk for breast cancer, but they are very cute, so you might want to. Birth control pills will decrease your risk for ovarian cancer. So my patients all want to know whether they should stop taking the birth control pills because they read somewhere it can increase risk for breast cancer. Take the birth control pills because it actually increases risk for breast cancer only very, very slightly, but it dramatically decreases your risk for ovarian cancer. I hope I'm getting a nod from my GYN colleagues. Okay, so we always encourage that. Hormone replacement therapy, on the other hand, we do try to avoid if at all possible. Alcohol should be, again, in moderation. Breastfeeding should be encouraged. Exercise and obesity, these things can be changed. The risk factors, though, I wanted to just let you know the relative risk factor for the BRCA mutation. Those are those mutations that women have that seem to have the cancer that runs in the family. And we can test their genetic makeup, and if they have a mutation, that delivers a 10-fold increased risk. Whereas all of these other risk factors are relatively small. That's why I'll be spending a lot of time talking about the risk factors for genetic history. You want to look for your patients or in yourself. If there are people in your family, multiple generations in the same family that have breast or ovarian cancer, any premenopausal breast cancers, the earlier the diagnosis, the more chance that it's genetically linked. If you have a bilateral breast cancer, you're diagnosed with breast cancers on both breasts, then you're more likely to have a genetic predisposition. The ovarian cancer, again, they run together. Some of the cancers are linked. and multiple other cancers in the family. If you just seem to have a family that has, everyone is coming down with cancer, you should definitely talk to a genetic counselor, a geneticist, or someone who knows. There are a lot of mutations. The BRCA1 and 2 mutations, they're two separate genes that have a number of mutations. They're pretty much divided into either BRCA1 or 2. What I wanted to remind everyone is that ovarian cancer is a big risk. So women who get tested for the BRCA gene after they already get diagnosed with breast cancer, they want to know, well, why am I bothering? They may want to know for their children or the rest of their families, but it really can help them as well because they're also at risk for ovarian cancer. They're at higher risk for second cancers, so women than someone else. Let's say my patient Jane was diagnosed with breast cancer, but she's not BRCA positive, but Jill is BRCA positive. Jill has a much higher risk of a second cancer. So Jill may choose a different treatment, say mastectomy, taking the whole breast, rather than removing just part of the breast, doing a lumpectomy. And men can get breast cancer. The men with the mutation BRCA2 have approximately 6% risk for breast cancer. That's close to just the average female. So we generally follow the men pretty much the way we do a woman with breast exams and mammography. It's a autosomal dominant inheritance pattern. So if someone in your family has the gene, it doesn't mean everybody does. It's only 1 out of every 2 people. So it's important for the rest of the family now to be tested for that mutation so they'll know whether they're at the average risk or whether they have an increased risk. A patient who does find out that she has the mutation, her risk goes to 56 to 85% by the age of 70 compared to the average woman at only 8.9. So it's a very important thing to test for. And again, we want to know it not just because we want to know, but because we can really help. We will increase the amount of surveillance so that if a woman chooses not to do anything special, like prophylactic surgery or any sort of chemo prevention, she will certainly be checked more frequently, and the breast cancer that's caught early is generally cured. So if we can catch an early stage breast cancer, for the most part, it can be cured. So we're going to do clinical breast examinations every 3 to 6 months. We're going to be doing recommending self-breast examination as we always do. Mammograms will be once a year, as well as MRIs once a year, and they should be done every 6 months. So if you're doing your mammogram in June, in December you'll do your MRI, and then you go back and do your mammogram again the next June. So every 6 months you'll have an imaging test. And prophylactic surgery for some women who are very concerned is an option as well. Screening is controversial here in the United States. Some people are concerned that perhaps screening is causing the cancer. You're radiating a breast every year for a woman for, say, 40, 50 years. If she starts at 40, are we causing cancer, or are we actually not preventing deaths from cancer? So there is a little confusion.
Oh my God.
The thing about the mammography, though, is if you actually do regular mammograms, when you catch a cancer, these are not actual sizes, but they're relative sizes, and you catch cancers, you diagnose them much, much earlier because they're much, much smaller. And if you look at the lower one and compare it to the woman who just happens to notice that she has a lump because she was taking a shower and felt it, that woman may not have as good an outcome as the woman who underwent the regular screening. So the American Cancer Society, and these are the recommendations that I follow, they recommend starting their mammograms at the age of 40 and doing them every year. Clinical breast exams should be every year, starting at the age of 40, but only every 3 years from the age of 20 to 40. Although I typically, if I see the patient, she's getting a breast exam. Okay? There's no harm in doing a breast exam, so more is better in my opinion. Self-breast exams are monthly, and they should start at the age of 20. They consider them optional. This is, again, one of the controversial things. I do not consider them optional. In fact, Lucy is over here, and she's going to help anyone who wants to after the conference. If you wanted to go over technique, Lucy has a few findings, and if you want to check her out, we can go over how to do breast self-exams. I don't think they're optional. The U.S. Preventive Services Task Force has different recommendations. They recommend starting with mammography, having it done every 2 years between the ages of 50 and 74. They say that women below the age of 50 should discuss things with their doctors and make a decision whether or not they should begin their screening. These are for average risk women. Higher risk women would have different guidelines. The average risk woman at 75, they're really not sure if there's any benefit to doing mammography, so they're not recommending it. They are also saying that clinical breast examination, it's really unknown whether there's any benefit or harm to doing. And clinical breast examination, I hope everybody understands, that means the doctor is doing the exam, compared to the self-breast examination where the patient is doing the exam. Now, digital mammography and MRI, they don't really know whether they're very helpful or not either. They actually discourage women from doing self-breast examinations. This was published shortly after these guidelines came out. It's the new mammographic screening guidelines. What were they thinking? This was written by a gynecologist, and this is pretty much the opinion of all of the people who specialize in breast cancer, all the oncologists, medical oncologists, radiation oncologists, surgical oncologists, radiologists, the OBGYNs. We don't really understand, because we know how many lives that we've saved. What they considered a risk or a harm would be maybe a woman getting nervous, finding a lump, being worried, going to the doctor, having even a biopsy, and it turning out to be normal breast tissue. And they feel that that's a harm. And it is. You know, it's a lot to go through. But if you're that one woman out of, say, 20 or 30 that had the cancer diagnosed and your life was saved, I think saving that one life is more important. And maybe some people go through a little anxiety or a little extra workup. Because I'm sure, I bet if I ask you, has anyone had a biopsy that turned out to be nothing, but you're glad you did it anyway, right?
Mm-hmm.
Twice, okay. I have a lot of hands here.
It's nervous. They did make me very crazy.
Uh-huh.
It was the gynecologist who thought he felt something under my arm, and and this was the second time I went to the breast surgeon. She said, you know what, if I had found it, I would have said nothing, but because he found it, I had to follow through, and they did send me for they did the biopsy, didn't get enough fluid, so I had to have the MRI afterwards.
Oh,
Yeah.
so you went through a ring, but it turned out to be nothing. So
It's nerve-wracking.
It is.
You have to wait.
Okay, and a lot I see that all the time, because 9 out of 10 biopsies turn out to be benign. But if you wait until your biopsy rate is higher, then there's a chance that you're going to be missing cancers in the earlier stages. So I think it's a personal decision, but I still recommend breast self-exams. And I wanted to go over a little bit about screening. This is why mammographies are so important, because when you do your mammogram, which is usually 2 views of each breast, and they're looking at it in 2 different dimensions, they may see something like the area on the left there, which could actually be nothing. Sometimes the density in the breast overlaps, and because it's just a 2-dimensional view, you see something and the radiologist is not sure whether there's really something there. What they do is they recommend that you come back and get spot compression views whenever they see a density like that. So when your patients get those, or you get the call that you have to come back, don't panic. Okay? If it's just superimposed tissue, what happens is they squeeze, everything separates, and it disappears. And that, more likely than not, that's what's going to happen. But sometimes it turns out to be a cancer, like this one on the right. And when you separate the tissue away from it, then the cancer stands out even further. So it's important. But most of the time, that's not what we find. That's what we find. And I try to, to alleviate the anxiety by explaining that everyone's just being extra careful. It's just important to go through this. It's probably not going to be a cancer, but just don't put it off. So you can get it off your mind. Okay, these are calcifications. Another thing we hear about a lot in the mammogram are the calcifications. Calcifications don't mean that you have cancer. They just want to look at them more closely. So if you see them in the regular views, they'll call you back and they'll want to do magnification views. So they'll be looking at it with a different lens, and they want to see the characteristics of the calcifications. Some calcifications are coarse, round, smooth, they may layer. Those are usually the benign calcifications, and they'll tell you so. They'll say, oh, they're layering, don't worry about it, come back in a year. They may not be sure, and those, they'll either recommend a biopsy or ask you to come back in 6 months. Generally, when you get a short-term follow-up, biorad 3, come back in 6 months. All those things pretty much mean the same thing. That gives you it's like a 1 to 2% chance that there may be a cancer there, something small that they can't really see. And in 6 months, it will either be more apparent or stable, and you may not have to worry about it. But then again, they may see fine pleomorphic branching types of calcifications. Those are the ones that we're more concerned about. And we usually would always recommend a biopsy for something that's described like that.
My hardest thing is to go get the examination, the mammogram. Is the hurting, the pressure, the squeeze. It's terrifying.
And they pull really hard.
And I think, what if a fire starts and everything? And it's the most painful thing.
Yeah, it is.
I wonder why they don't have an emergency release button for you. What if the technician just passes out right there while he's doing it?
But is there another type of technology where they could just...
There's really nothing that can replace the mammogram. They have a new type of mammogram. They have a 3D mammography, tomosynthesis, but they're still doing the same thing. They're doing the 2 views, plus then they do one that's similar to what the dental x-rays were, where they had the machine that goes around. Sorry. Panorex, okay, very similar technology. It took a while to get it approved, but it's approved now. And the reason why it took a while, they wanted to make sure that the radiation dose isn't higher than a traditional mammogram. So it's slightly higher. That's one thing. Whenever somebody's offering you a new test, something new and great and the latest thing, find out how much radiation is involved. Because the mammogram is fairly low. Basically the same radiation as anybody who may fly back and forth to California a couple of times. So it's not a lot of radiation. Where some of the newer tests, the gamma imaging, those things are very high radiation levels.
Could you talk about thermography and how valuable or invaluable?
People are testing it. It's pretty much all the people using that technology are on protocol. It hasn't been proven to be as effective as mammography. That's one of, but doesn't have radiation, so it's certainly something good. Use it for patients that can't do a mammogram, because when you have to actually be able to stand or at least sit and move properly to do the mammogram. So sometimes we'll use things like that or PEM imaging, but it's not widely used as screening. Okay, same as ultrasound. Ultrasound is also not used for screening. Ultrasound is more used for getting further characterizing something you see on your mammogram.
How are male tested for? How are male tested?
Oh, they get mammograms. They have breasts. They do.
Same way?
Okay, this is used for screening. MRI is used for screening, but only for high-risk women. And the reason why we don't use it for everybody is because there are a lot of false positives. A lot of people They see lots of little things, and if you're not at high risk, the chance that all these little things that they're going to see are it's going to turn out to be nothing more often than not. Even the patients who have breast cancer, and when MRI is recommended to help plan the surgery to see the extent of disease, it may overemphasize areas that may just be benign tissue. So people argue back and forth at all of the conferences whether to do it or not, because some people feel that doing MRI may cause people to have unnecessary mastectomies when by giving them extra things to worry about. Maybe they see a little something on the other breast, and then the women say, "Oh, just take them both off." Instead, if we just treated them, more conservatively, they'd be able to conserve their breasts. So it's a little controversial. What you want to look for, though, as a physician, a clinician, and yourself and your family, are these signs. You're going to see a painless lump or thickening. Breast cancer generally doesn't cause pain. It can in a later stage if it's invading muscle underneath. So it doesn't mean that because it hurts that it's not cancer, but it usually doesn't. Thickening or swelling that persists, nipple pain, retraction. You're looking for breast skin irritation, dimpling, or some sort of spontaneous discharge from your breast or from the nipple. The breast self-exam is very important. Even with all of our technology, approximately 70% of all cancers are still found by women on their breast self-examination. So I really want to emphasize how important this is. And I'm going to say it over and over again, but the goal is really to become familiar with your breast and to know what is normal for you. But it doesn't replace your regular mammograms and your regular visit to your doctor. If you are still getting your period, the best time to do it is the week after your period. If you're not getting your period or it's irregular, you just want to do it once a month, and just mark it down, don't forget. Okay, doing it more than once a month is not going to be much more helpful, because you want to see a change, and if you're doing it every day, you may not notice a subtle change. So not every day, not every time you take a shower, but once a month is very reasonable. You want to visually inspect your breast and also palpate your breast. People forget to look. Most of my patients, when they say they're doing breast self-exams, it means that when they lay down at night, they felt it, or while they were in the shower, they felt. No, very few of them tell me they were standing in front of the mirror doing it the proper way. Okay? What are you going to look for? Again, you're going to look for changes in shape, size, color, texture, discharge from the nipple. Anything that makes one breast look a little different than the other, that's a change. If one of your nipples has been inverted, not sticking out at the same amount as the other, but you've had that since you were 5, and now you're 75, that's not cancer. If it hasn't changed in 70 years, it's fine. But the very same thing in a woman, if it just happened 6 months ago, you're going to look into it. Okay, you want to include all of your breasts. Your breasts go all the way up to the collarbone, the clavicle here, all the way into your axilla, the armpit. It goes all the way down to even a little bit below your breast, okay? And some people even have extra breast tissue. If you've seen patients with extra nipples, it's very common to have those extra nipples. They may have breast tissue in odd places. If you see lumps popping up anywhere, check it out, okay? And again, know what's normal for you, okay? We're all not perfect. We all don't have the same color breast, are the same texture, the same, some are lumpy, some are not, but if you know what's normal for you and there's no change, then you should be fine. You want to look in the mirror and then make sure you have good lighting. You want to look straight ahead, then you're going to go from side to side. You want to raise your arms so that you're looking with your arms up in the air, because that way you'll see some dimpling. You want to put your hands on your waist and lean forward, because you also may pick some dimpling. You'll see retractions that way. People forget this part, okay? This is the leaning forward. This is demonstrating how to do this. How many people in here do this part? I'm sure. Do you guys do breast self-exams? Anybody? Raise your hand. How many look in the mirror and lean forward?
Lean forward? No.
Okay. 1, 2, 3, 4. Okay, well, it's about...
one.
Okay, well, a couple of you. I see Dr. Watson's been taking good care of herself, so that's good. These are some things that you may find if you wait a little bit too long. These are all advanced cancers. Maybe not the discharge, but this is what I'm talking about, dimpling. A dimple is really cute if it's in your cheeks, not so much anywhere else. So if you see a dimple, it means that it might be nothing. You know, it could just be some scar tissue. So no one assume that there's a cancer until you know there's a cancer. But the cancer can cause dimpling, and it's a very important thing to check out. The skin up there that looks like an orange peel, that's called peau d'orange. That happens when the lymphatics get blocked with cancer cells. So it happens in an aggressive form of cancer called inflammatory cancer. The bloody nipple discharge, it could come from one or multiple ducts. That's a sign that there's a growth inside the breast called a papilloma. About 15% of those are cancerous, so you want to always check out if you start having discharge for no reason from one breast. You want to look and evaluate for cancer. It's rare that you're going to get it on both sides at the same time, but you still want to check that out too. This woman on the left, in the bottom left, that was a woman who was just afraid to get treated. And she waited and waited until she was changing, and her mom happened to walk by and notice and dragged her in. And the poor woman had stage 4 breast cancer. Could have been cured if she had been treated earlier, but she was not. It's not curable once it's spread into other organs.
Yeah.
This is another, the middle on the bottom is also another picture of the inflammatory breast cancer. I have 2 pictures of that because I think it's so important, because women see this and they think it's an infection. Even doctors see it and think it's an infection. I don't think there's a woman diagnosed with inflammatory breast cancer that didn't try a course of antibiotics first. Not that there's anything wrong with that. If you're going to treat with antibiotics because it looks like an infection, just make sure the patient comes back in a week or 2 and it's gone. If it's not gone, it needs a further workup. Okay, because it looks exactly like an infection. And then the other slide is something called Paget's disease. It's when the cancer comes out through the nipple. And it starts out looking just like maybe a little fungal infection, a little irritation. It starts out looking like nothing. And then it can turn into something that looks a little more ominous. Okay, now when you're going to start feeling, you want to feel with the soft parts of your fingers and the pads. Okay, and you're not pressing down hard. It shouldn't hurt. Okay, some doctors even don't know how to do it. I see some of the medical students. It shouldn't hurt to do a breast exam. You should just be able to check with and know what's normal for yourself and feel if something changes. Some part of your breast feels different than the other parts of the breast, and it's not symmetric on both sides. There may be a problem. And again, you're feeling for lumps, thickening, anything that wasn't there before. Okay, a change. Did I say that enough? We're looking for changes. Something that's abnormal, something that makes one breast feel different than the other breast. There we go. And I just wanted to put these slides up just to remind you about the different things that you may hear about when you talk about diagnosing breast cancer. There are different types of biopsies. They can be diagnosed based on your clinical breast exam, diagnostic mammography, your breast ultrasound, MRI, and then there are fine needle aspirations, core needle biopsies. They could be vacuum-assisted or image-guided, excisional biopsies, incisional biopsies. It's not the same for everyone. So if you have a problem and your doctor recommends one thing and then your next door neighbor has a problem, her doctor recommends something else, there's nothing wrong with that because there are different types of biopsies for different types of lesions, for different types of people. Some people need general anesthesia, they need to be asleep to have a biopsy. Some people are just fine if it doesn't hurt. So there's different things for different people, and just know they're out there. And if you have any specific questions, we can talk about it later. And then the treatment, again, is also different for everybody. Everybody's treatment's not the same. Some people have just the lump removed, some people get radiation, some people don't. Some people need the whole breast removed, some people don't. Some people just choose to get the whole breast removed, even though they don't have to. But it's all personalized. The chemotherapy is also personalized based on the tumor characteristics and also the patient's state of health. Okay, radiation, again, there are different types of radiation. So don't, this is only 30 minutes. I can't go into a lot of this, and I probably already outspoken. But there's just it's such a diverse group of treatments, so don't feel like something bad happens to you because you didn't get the treatment that your friend got. Everybody's not treated the same way. All the cancers are different. Okay, now here's a little quiz because I expect everyone to get all of these answers right now. Okay, what age should a woman first start doing her breast self-exam?
20.
20. Everyone got it right?
Yeah.
Yes? Okay. How often should you do it?
Once
a month. Yes. At what age should you start having a yearly
40.
mammogram?
40.
Okay, if you're at average risk, 40. High risk patients are going to start earlier. 40, right. And when, how often should a 20-year-old woman have her clinical breast exam?
Once a year?
Oh, every 3.
Okay. I put every 3 years, but every year is not a bad idea. Okay, I still have to go with the American Cancer Society, but my own take is once a year I think is very important. And what are you going to look for? Change shape, size, all of the above, yes. Thank you. And there's my email address if anybody wants to send me a question or talk after we leave today. Thank you.
We give you this plaque,
Oh,
appreciation for your performance.
thank you so much. That's beautiful.